All right. So, when you think about a medical crisis in a hospital setting, I feel like at times it can be pure chaos. I mean, I hear the alarms going off, doctors and nurses rushing in and out. There's a sudden influx of activity, and sometimes everything is just crashing at once. It's so loud, and it's very obvious that something is going on, right? But what if one of the most dangerous things the human body can do is just quietly tell you a lie? Like, what if the body is in this absolute catastrophic free fall, but on the surface, just looking at the monitor, everything looks perfectly fine? The human body is just a master illusionist when it comes to this stuff. It will use every single physiological trick it has to maintain the appearance of stability, even when it is literally starving to death at the cellular level. Welcome to our deep dive. Today, I'm taking you right to the bedside. I'm going to explore the pathophysiology and the management of hypovolemic shock. And I'm tailoring this specifically for nursing practice because I know that as a nurse, you are the one standing in that room when the illusion finally bursts, right? You now become the absolute first line of defense in situations like this. And being that first line of defense means you just cannot afford to be fooled by the body's compensatory mechanisms. You need a solid framework to see through the facade, which is exactly my mission for this deep dive. By the end of our time together, you are going to understand the mechanisms of what I call the cardiovascular plumbing model. And it's a great model, it's super helpful. And you're also going to know exactly why the golden rule in resuscitation is literally always fill before you squeeze. And finally, we'll uncover why checking serum lactate is the ultimate undeniable truth teller when you are fighting to save a patient's life. So, to really grasp how to fix the problem of hypovolemic shock, I think we have to start with the machinery itself, which is the plumbing. The clinical framework I'm using relies on the cardiovascular plumbing model. Now, I know every nurse understands the concepts of preload and afterload, right? But stripping it down to this plumbing analogy, it just lets us visualize the pure mechanics of the crisis before all that compensation kicks in. I love this model, honestly, because it bypasses the heavy medical terminologies and gives us this very clear mechanical picture. So think of the patient's body exactly like the plumbing in a house. You have three main components. The first one is the tank that represents the vascular space, which is where all the fluid actually lives. Then you have the pipes, that is the vascular network. So all the arteries and veins run through the system. Finally, you have the pump, which is the heart. And if you break down the word hypovolemia, it literally means low volume. So the enticing incident of this entire crisis is simply the tank is emptying out. It's got a leak, right? So, mechanically, when there is less fluid in the tank, there is decreased blood return to the pump, and that returning volume, that is your preload. So, less water coming back to the pump just naturally means the pump has less water to push out on the next beat. And that volume pushed out with each individual beat is the stroke volume. So, when preload drops, stroke volume plummets right along with it. And because the heart is pushing out less fluid with each heartbeat, the overall continuous circulation of the entire system begins to fail. That is your cardiac output dropping. And this is a serious threat. This fluid is carrying the one thing every single cell in the body needs to survive: oxygen. So when cardiac output drops, we reach a state of global tissue hypoperfusion. The organs are actively starving. Cellular hypoxia sets in, and this is exactly where the body's survival instinct kicks in and initiates what I call the vicious cycle. Why do I call it the vicious cycle? Because we have to look at the math the body is constantly doing behind the scenes. The defining formula for perfusion, which we use to diagnose the root cause of shock, is mean arterial pressure, or MAP, equals cardiac output multiplied by systemic vascular resistance, or SVR. Now, you may be thinking, if the cardiac output is dropping because the volume is going down, would it not be the body's automatic defense mechanism to massively increase the systemic vascular resistance, which basically means clamping down the pipe and beating faster? Would that not mean the blood pressure will go up? And I would say mathematically, yes. But you may then say, if you are looking at the monitor, a normal or even rising blood pressure looks like a patient who is stable and not crashing. Why is that a bad thing if they are looking stable? And I would say you've just identified the exact trap that catches so many clinicians, and it's so common. Mathematically, if cardiac output goes down, the body skyrockets the systemic vascular resistance to keep the mean arterial pressure normal. But think about how it increases that resistance. How does it do it? It does it through massive vasoconstriction. It clamps the pipes down incredibly tight, so the pressure number on the monitor looks great, but the pipes are so narrow that hardly any blood is actually getting through to the organs, and this can be misleading. The pressure is maintained, but the actual delivery of oxygen to the tissues is severely compromised. The body is dangerously masking the shear volume deficit to keep the pressure up in the core. It just hides the crisis from you until the sheer lack of volume overwhelms the entire system, which means as a nurse, you can't just trust the blood pressure cuff at first glance. Since we know the body actively hides the deficit, we need to understand how that volume is lost in the first place, and more importantly, what it looks like when that physiological mask begins to reveal itself over time. So, broadly speaking, the causes of this volume loss fall into two distinct categories, or two different ways of the tank to leak. You have hemorrhagic and non hemorrhagic. But hemorrhagic is probably the most intuitive one. It's the loss of whole blood. Your patient will lose red blood cells, platelets, and coagulation factors. So you may see this with your trauma patients, severe GI bleed patients, postpartum hemorrhage, or maybe even a ruptured aneurysm. Then you have the non hemorrhagic shock. The mechanism here isn't bleeding out, but rather massive fluid loss, or what we call third spacing. So your patient is losing plasma, water, and vital electrolytes, leaving the red blood cells behind in this shrinking pool of fluid. So imagine a patient who has had severe vomiting and diarrhea for 3 days, or someone with a massive burn where the fluids are just weeping out of the tissues. It could also maybe be a patient who received aggressive diuresis, or conditions with ascites where the fluid escapes from the vascular space and builds up in the abdomen. So, regardless of whether it's blood or fluid, the volume is leaving the body, and it goes through four progressive stages of failure, which are categorized as four classes of shock. Okay, so let's walk through what you actually see at the bedside as this compensation eventually collapses. Now, I want you to imagine yourself in the patient's room. Class 1 is our starting point. This is where there is less than 15% of blood loss. And honestly, if you look at a patient in class 1, everything looks fine. They look completely normal, their heart rate is normal, blood pressure is normal, respiratory rate is normal. They're making plenty of urine and they are fully alert. It is essentially the physiological equivalent of donating a pint of blood. So the body's compensatory mechanism handles it seamlessly. right? We usually just treat this by replacing the fluid with some crystalloids. Simple enough, right? But if the leak continues, we move into class 2, which is 15 to 30% blood loss. And this is where the mask starts to be removed just a tiny bit. The heart rate starts to creep up. You're looking at about 100 to 120 beats per minute. Now, their overall systemic blood pressure is still technically normal, but the pulse pressure starts to decrease. Their skin might feel a little cool and clammy, and they start acting mildly anxious. They just feel a little off, right? So, now what's fascinating here is the mechanism behind that decreasing pulse pressure. So the pulse pressure is simply the difference between the systolic and the diastolic numbers. And remember how we said the body clamps down the pipes to increase resistance? That vasoconstriction actually drives the diastolic pressure up. So the systolic number stays the same, but the diastolic number creeps closer to it. The gap narrows. So a blood pressure between 120 over 80 might become 115 over 95. Now, your monitor is not going to flag this as hypotension, but that narrow gap is a massive warning sign to us that the pipes are clamping down hard, and that mild anxiety your patient might be experiencing is the brain starting to sense the impending um, shortage of oxygen. It's sending a panic signal to them. It's pulling the alarm, basically. But notice the systemic blood pressure hasn't actually crashed yet. That brings us to class 3, which is the critical turning point, 30 to 40% of blood loss. And here's where it gets really interesting to me. A patient can lose up to 30% of their entire blood volume before their blood pressure actually drops. That's wild. 30%. That is almost a third of their tank gone, while the monitor tells you their pressure is fine. If you are waiting for the blood pressure to tank before you recognize shock, you're already behind the curve. It's a terrifying reality for us. By the time you hit class 3, the compensation is actively failing. The heart is beating well over 120 beats per minute. It's working so hard. The respiratory rate spikes to 24 because the body is desperately trying to pull in more oxygen to make up for the lack of delivery. Urine output significantly drops, and that mild anxiety turns into severe confusion or altered mental status. So the intervention here has to be immediate and aggressive. You are hanging crystalloids, colloids, and likely albumin to try to pull volume back into the vascular space, because if you don't reverse it here, you will hit class 4, and that's the final stage. This is more than 40% blood loss, complete physiological collapse. The tachycardia is extreme. The systolic blood pressure is finally less than 90, and the pulse pressure is razor thin, often less than 25. Your patient's skin is ice cold and pale or grayish. The patient is profoundly lethargic or unresponsive, and the kidneys are completely shutting down. I mean, urine output is pretty much minimal to non existent. Watching that progression from class 1 to class 4 is like watching an engine slowly seize up from a lack of oil. So we understand the math now, and we know the vital sign parameters. But as a nurse actively assessing a patient, how do you visually see that the organ starvation is happening in real time? You have to look at the physical signs of vascular shunting. When the tank is running dry, the body is forced to prioritize. It cannot afford to perfuse everything, so it makes choices. I always picture it like a city undergoing extreme financial triage. So when the body's economy is going bankrupt on oxygen, it has to make brutal cuts. It instantly cuts funding in the suburbs, so the skin, the extremities, the kidneys, all in a desperate ditch attempt to protect the city. which is the brain and the heart. We can see this triage in action through three specific bedside indicators. First, let's look at the capital city itself, the brain, which serves as our neurological indicator. The brain is an absolute oxygen glutton. It loves oxygen. It demands a constant heavy supply. So, as cerebral hypoxia sets in, as the oxygen delivery drops, you see the altered mental status unfold. That is why the patient in class 2 is anxious and restless. Their brain is pulling the fire alarm. By class 4, the brain is so starved it shuts down entirely, leading to profound lethargy and unresponsiveness. Next, we assess the suburbs, which is the skin, which is our peripheral indicator. Because the body is aggressively shutting blood down from the extremities to keep it circulating in the core, the periphery suffers first. This is why you see increased capillary refill time, like when you press on the patient's nail bed, blanching it white, and then it takes longer than 3 seconds for the pink color to return. The blood is just moving too sluggish. So it also explains why the skin becomes visibly pale or grayish, cold, and clammy. The heat and the color of the blood are literally being drained from the surface. And finally, we look at the ultimate suburb, the organ system that often takes the hardest hit to save the rest, and that is the kidneys. This is our renal indicator. They sacrifice themselves. The kidneys are incredibly sensitive to flow. When they sense a drop in volume, they trigger hormonal pathways to desperately conserve whatever fluid is left. They stop filtering out water and start hoarding sodium, which pulls water back into the body. And the physical result of that hoarding is oliguria, which is a severe sudden, like decrease in urine output. And if we connect this to the bigger picture, well, these aren't just isolated random symptoms to be checked off on an assessment flow sheet. They actually tell a story. And the anxiety, the delayed capillary refill, the lack of urine in the Foley catheter all tell a story. They are interconnected alarms. They are screaming that tissue ischemia is happening right now. The organs are suffocating and the body is sacrificing its own parts to survive another hour. So the alarms are ringing, we know the tank is empty, and we see the body desperately shunting blood away from the skin and kidneys. How do we intervene without making things worse? That is the $1 million question. Because frankly, if I'm a newer nurse, let's say in the ICU, and I see my patient's blood pressure dropping into the 80s, my very first instinct might be to reach for medication to fix that specific number, to fix the monitor and not the patient. I mean, if the pipes are too loose, why not just hang a bag of norepinephrine or another vasopressor to squeeze the pipes and shoot the blood pressure back up? It's a totally logical thought process, but in the specific context of hypovolemic shock, it can be a lethal mistake. You are probably like, lethal? What do you mean lethal? Imagine a skeleton hand tightly gripping and squeezing an entirely flat, empty plastic bag. It's like trying to wring water out of a dry sponge. Using vasopressors without replacing the missing volume first is literally squeezing an empty tank. Mathematically, the drug will increase that systemic vascular resistance. The pipes will clamp down even tighter, and you might even see a blood pressure number on the monitor that looks a little better for a few minutes. But that's a trick, a total trick. Think about the plumbing model. There is no actual fluid in those pipes. So if I'm clamping down pipes that are already basically empty, I'm just closing them completely. I'm forcing chemical vasoconstriction on an already volume depleted system and actually worsening the tissue ischemia. You are completely cutting off whatever tiny microscopic trickle of blood that was still making its way to the kidneys or the gut. You are actively accelerating cellular necrosis and would be starving the tissues faster just to make the monitor look pretty, which leads us to the absolute golden rule of hypovolemic shock management, which is to fill before you squeeze. You must restore the volume first. The physiological goal is to open the pipe wide with a massive volume of fluid rushing through it. Aggressive volume resuscitation restores the venous return. It gives fluid back to the preload. And when the heart actually has fluid to pump, the stroke volume naturally fixes itself. The cardiac output will go up and the tissues finally get their oxygen. But you can't just blindly dump any fluid into the tank, right? You have to match the fluid to the leak. And like I mentioned earlier, if the patient is in hemorrhagic shock, meaning they lost whole blood, you have to replace it with blood products like red blood cells, plasma, platelets. And obviously, the first step is to stop the bleeding. Okay? But if it's a non hemorrhagic fluid loss, like our patient who's been vomiting for days, you replace that specific fluid with crystalloids and electrolytes. So you match the solution basically to the problem. So let's say you've done everything right. You've identified the leak, you've stopped it, and you are aggressively filling the tank with the right fluids. Now comes the hardest part of resuscitation. How do you actually know if it is working? So, as a nurse, we always like to evaluate our intervention. So, we want to know whether our cells are happy again. We can look at the macro view first, the big systemic bedside victories, like the plumbing check. So, we are looking at three specific goals to be met here. One, we want a mean arterial pressure or MAP greater than 65. That tells us we finally have sufficient perfusion, pressure pushing through the pipes. Two, we want to see the urine output recover that and that the kidneys are waking up, right? Our goal is to have a urine output greater than zero point 0.5 ml per kilo per hour. That indicates the kidneys are no longer hoarding fluids and receiving adequate perfusion. And three, we check the peripheral indicator again. We want a capillary refill time of less than 3 seconds, showing that rapid blood flow is returned to the suburbs. So, what does this all mean? If I look at my patient and check those three boxes, the map is 70, urine is flowing into the bag, the color has returned to their fingers. Can I finally relax? Is my patient officially saved? This is incredibly tempting to think so, but the answer is no. Those macro indicators are vital, but they only tell us that the plumbing is starting to work again. They do not guarantee that the actual cells have recovered from the trauma and starvation. Okay? For that, we have to transition our focus from the macro view down to the micro view. We need to look at the lab results, specifically serum lactate. It's so critical when evaluating shock. To understand the power of lactate, you have to understand how a human cell actually breathes. Normally, when cells have plenty of oxygen delivered by the blood, they use aerobic metabolism. It is incredibly clean, efficient energy production. When cardiac output plummets during shock or and oxygen is cut off, the cells don't just immediately die. They switch to an emergency backup generator, which is anaerobic metabolism, meaning functioning without oxygen. But that backup generator comes um, with a steep cost, right? Think of anaerobic metabolism like burning wet wood inside a house with no chimney. That would be awful, right? It creates a little bit of heat to keep you alive for a minute, but the house fills rapidly with toxic, choking smoke. In the body, that toxic smoke is lactic acid, which we measure with serum lactate in the blood. So, a high or steady rising lactate level means the cells are actively suffocating and relying on that dirty smoke production. um, that was backed up in order to survive, which means if your resuscitation is working, if you are filling the tank and oxygen delivery is actually being stored all the way down to the microscopic cellular level, those cells will finally turn off the backup generator and they will switch back to normal, clean, aerobic metabolism. And when they stop burning the wet wood, the smoke finally clears. The body metabolizes and clears out that accumulated lactate acid, okay, or lactic acid. Now, if you trend the serum lactate, you should see a beautiful steep downward curve from a high dangerous red zone dropping steadily down to a low healthy green baseline. That decreasing serum lactate, what we would call is lactate clearance, and it reflects resolving tissue hypoxia. It is a definitive marker, the real proof, and it is the ultimate truth teller because the cells can't lie. It is the only way to know for absolute certainty that oxygen delivery has truly been restored, which brings us to the ultimate protocol for managing those critical patients. It is a continuous four-step cycle called the resuscitation loop. Step one, identify the source of the leak. Step two, fill the tank. Remember the golden rule, fill before you squeeze. Step three, check your vitals. And step four, check the cells, assess the lactate clearance. We have covered an immense amount of ground here today. And whether you are a nursing student preparing for your clinical rotations or a seasoned nurse, keeping this specific framework in mind changes how you look at your patients. It really does. And so I just want to say thank you for joining me on this deep dive. Keep questioning the monitors, keep looking for the truth at the cellular level, and we'll see you next time.